But why don't we go ahead and get started? So thank you everybody for being here. Welcome to February. Thank you also to our host institutions who moved this so that we're not doing it on Valentine's Day, although I am sure that everybody would find that this is the most fun place you could be on Valentine's Day. So we are doing our February version of the JVS Online Journal Club. Tonight, we are lucky to have the SUNY Upstate Medical University, who is hosting along with Indiana University. We have two exceptional papers that we will be discussing and are excited to have the presenting authors and faculty, the presenting residents and faculty, as well as some of the authors with us. From Upstate, we have Dr. Anthony Fagali, who is an assistant professor of surgery, and joining him to present will be his second-year vascular fellow, Dr. Dina Chide. From Indiana University, we have assistant professor of surgery, Dr. John Mayoub, and then, of course, Dr. Rohan Basu, who is his second-year resident, who will be presenting for us tonight. We're thrilled to have the authors from the sartorius paper, Dr. Zachary Williams, who is the chief of vascular surgery at the Durham VA, and also his fourth-year resident who was on the paper, Dr. Roberto Loenzon, who is going to be here to answer questions that we send towards them. And then our special guest, editorial guest, is Dr. Hassan Dalovu, who is going to be helping us in terms of moderating. The Japanese authors from the other paper were unable to make it. So I think when we get to that article, we'll have some time to discuss it as a group, and we'll invite questions from all of the participants and maybe even some discussion from those of us that are on the call. We have just a few housekeeping issues, so we ask that you please stay muted. If you do have questions and comments, you can place those in the chat, and Hassan or Paul or myself will kind of go through those and make sure we get them addressed. The event is being recorded for on-demand access. Please join us again in March for the Wednesday, March 13th, JVS Online Journal Club, which will be at 6 p.m. Central Time. The University of Buffalo and the University of Washington will be hosting. We also have put out all of the dates for the rest of the journal clubs through December. When I send the March update to the program directors, I'll make sure to include all of those, and we'll also be posting those in SVS Connect and in the APDVS version of SVS Connect. So with that, I will stop sharing my screen and we will turn it over to our first faculty and we will get started.
All right. Thank you, Missy and Paul, for inviting us to present. It's a privilege to be here. I'm Anthony Fagali. I'm one of the vascular surgeons here at SUNY Upstate, and I have my second-year fellow, soon to graduate, Dr. Shahad, who will kind of get more into the paper. But as we get started, it's really looking at an outcomes between bypass and endovascular therapy for dialysis-dependent and independent patients with really CLTI, and really what are their outcomes. And so the paper, it was really to look at limb salvage, wound healing, and dialysis-dependent versus independent patients with chronic limb-threatening ischemia, and to compare them to what is better. Is it endovascular therapy or an infrainguinal bypass? And what is the best therapy to provide them? And it was a retrospective analysis. This is just a 360 overview. All based out of Japan, and they looked at the Wi-Fi criteria, which is the wound, ischemia, and foot infection stages between 2 and 4, and they did so over a 5-year period. And their primary endpoint was to look at limb salvage. Their secondary endpoint was wound healing, amputation-free survival, complications, and 2-year survival. And so just to kind of review and refresh for all of us, the trainees, what is the Wi-Fi? We heavily use it here at SUNY Upstate. Actually, Paul Mashaw has really been instrumental in bringing it to us. But really looking at the wound, ischemia, and foot infection. It's a classification that as the wound gets larger, more extensive gangrene, the number goes up. It looks at ischemic based on the pressure of the toe. Of course, below 30 is poor perfusion, greater than 60 is ideal. And then foot infection, how bad is the infection? Is it very cellulitic? Is it not? And as that number gets higher, as you can expect, the amputation and loss of limb goes up. And this has really been looked in the data from SVS in a lot of studies. And this was just a large a study back in 2009, multi-center study, really seeing how it affects these patients. And they broke them down in quartiles. And essentially, the patients with the highest level of the Wi-Fi value had the highest incidence of amputation rate, up to 50%. And again, this is just showing that should you revascularize these patients with a very high level of tissue loss, gangrene, cellulitis, and really their 1-year foot healing rate was pretty poor, and about a quarter of these patients lost any sort of revascularization option. The other part they look at is the global limb anatomic staging system, or the GLASS, and they look at both the FIM-POP, the infra-POP, and then the inframalleolar classification. And is it similar to Wi-Fi? As that value goes up, the worse the outcomes are. And just quickly to refresh, kind of similar to the task classification, this is really looking at the length of the lesion. Is it something that you can cross? How bad is that CTO? And it's either above the pop, below the ankle. And so as you expect, as that GLASS classification gets worse, the reintervention rates go up, the 5-year reinterventions go up, restenosis. And really, this is looking at endovascular therapies. This doesn't evaluate the vein conduit or any surgical options. So it is a bit limited for that, but they use both the Wi-Fi and the GLASS for this study. And so with that, I'm going to turn it over to Dr. Shahade and let her get started. And I'm going to stop sharing so she can get this.
Dr. Fagali, thank you for the introduction. My name is Dina. I'm the fellow here at Upstate. So kind of to add to the background, we know a lot about Wi-Fi in all comers and diabetic patients. However, Wi-Fi and CLTI is still kind of argued about. One thing that we can agree on is CLTI and dialysis-dependent patients is well known that dialysis-dependent patients do poorly. In previous studies, such as this one, looking at patients that have undergone intervention, either bypass or endovascular, and they looked at the similar endpoints to this paper, which is amputation-free survival, death, amputation. They noted that the amputation-free survival, major amputation, and survival in and of itself were noted to be worse in the dialysis-dependent patients. And not only that, but the risk of major amputation or death was almost 2 times higher in the dialysis-dependent patients, death in and of itself 3 times higher, and major amputation 2 times higher. So just to look at the CLTI guidelines, this is the traditional pathway that Conti put out. One thing that all of us clinicians look at after a target arterial path or a conduit is kind of looking at the estimated procedure risk and 2-year survival, and where do our patients fit into that? And then we also want to approach a patient with an evidence-based approach of revascularization, and that's the plan approach. And the plan approach basically looks at P, which is patient risk, L, limb severity, and AN, the anatomic approach using the scoring systems that we mentioned before. And then you split your patients into an average surgical risk or a high surgical risk. And if you have an average surgical risk, your interventions that are delineated in the CLTI guidelines are kind of decided for you in a way. There are some gray areas. However, when your survival is less than 50% at 2 years, or your peri-procedural mortality is greater than 5%, like a lot of our dialysis patients, it's relatively unknown or a gray area. So just to get into the demographics, the patients in the bypass group were notably older, had higher rates of hypertension and coronary artery disease. They also skewed towards higher Wi-Fi stage and GLASS stage in the bypass group versus the EVT group, which is the endovascular group. The bypass group skewed more in the P0, P1 on the inframalleolar modifier, while the EVT group skewed P1, P2. The majority of patients in both groups prior to propensity score matching were in the P1 inframalleolar modifier. So for the results, limb salvage, this is a Kaplan-Meier curves, which I'm going to show on the next 3 slides, but the limb salvage rate of bypass surgery was better than that in endovascular therapy in the overall cohort and in dialysis-dependent patients. However, there's no significant difference in the dialysis-independent patients. And similarly, amputation-free survival was also better. The rate was better in bypass surgery than that of EVT in the overall cohort and in the dialysis-dependent patients, and no difference in the dialysis-independent patients. Wound healing is really important when you have extensive tissue loss and your goals of life are to have a good quality of life. So in the overall cohort, the wound healing rate of bypass surgery was better than the endovascular intervention, and wound healing rates of bypass were better than those of EVT in both the dialysis and dialysis-independent patients. So bypass is the way to go. One important part of this paper and how this is going to kind of help us on our day-to-day for CLTI patients with dialysis dependence is kind of determining the risk factors and 2-year survival. So they did a multivariate analysis identifying risk factors for the overall cohort compared to the general population. Additionally, they parsed what risk factors were important for dialysis independence and dependence. And the three, actually, they came up with 4. So we all know dialysis in and of itself is a risk factor. Endovascular therapy was a risk factor for dialysis-dependent patients, in addition to age greater than 75, poor functional status, so non-ambulatory, and a serum albumin of less than 3.5. So what they decided to do is they decided to look at these risk factors and survival and parse out what the 2-year survival is per number of risk factor. So if you have a dialysis-dependent patient with 0 risk factors, 82% are deemed to survive by 2 years. And then if you have one of the risk factors that I mentioned, 67%. And at this point, you cross over into the less than 50%. So if you had 2 or more factors, your survivability was less at 2 years. So what does this mean for amputation-free survival? So these are the 2 Kaplan-Meier curves for amputation-free survival. It shows that the patients, these are both dialysis-dependent patients, those that had undergone bypass had greater rates of amputation-free survival over EVT if they had 0 to 1 risk factors, so gold standard bypass. However, given patients that had 2 to 3 of the risk factors I mentioned before, bypass did not rescue those patients over EVT. So just for a discussion, wound healing, both cohorts benefited from bypass over EVT. There are plenty of papers that have published this before. Okazaki in 2018 showed that wound healing improved with bypass over EVT. With dialysis-dependent patients, if you look at the table on the right, showing a relative risk of 2.26 of worsening or encountering wound recurrence and against amputation-free survival. Hana and Kobayashi also agreed. Both demonstrated dialysis dependency as a risk factor for impaired wound healing, where you can see the cumulative achievement of wound healing at 3 years in Okazaki's study also showed that dialysis-dependent patients was a huge risk factor for achieving a lower percentage of wound healing, 60% versus 84.6%. Therefore, in conclusion, with this discussion point, bypass surgery should be the preferred initial revascularization for all comers, whether dialysis dependent or independent patients with tissue loss. In terms of risk factors, dialysis dependency, as we can all agree, is poor prognostic factor for 2-year survival. A 2-year survival can be achieved greater than 50% if you look at patients that only have 0 to 1 of the risk factors that I've highlighted above and mentioned before. In terms of limb salvage, bypass provides better limb salvage in the EVT and dialysis cohort specifically. This was echoed in Hicks' paper from 2018, where she showed that HD patients demonstrate worse outcomes after EVT in terms of primary patency, secondary patency, major amputation, amputation-free survival, and mortality. This was also echoed in Ramanan's paper from 2019, where dialysis patients fared better in terms of limb salvage with bypass over EVT. So as we kind of have progressed in our careers, we've noticed a kind of a change in a patient-centered approach. We are given national guidelines to abide by, but when we have a patient in front of us, we kind of have to mold the guidelines to the patient that's sitting in our clinic or in the hospital. So patient risk and two-year survival must be considered when choosing a revascularization strategy. So you can do your targeted arterial path mapping, but you have to look at the risk. This study does demonstrate that dialysis dependency is a poor prognostic factor for two-year survival. However, if you were to look at the factors that listed in this paper, you can identify those that are expected to have greater than 50% survival at 2 years. So in conclusion, bypass surgery should be the preferred method of revascularization in patients who are dialysis dependent with 0 to 1 risk factors defined in the study. Within the EBT group, 54.4% of dialysis dependent patients had only 0 to 1 risk factors. So ideally, they could have rescued those patients from the EBT group pending if they have a conduit, according to best CLI, and they would have benefited from bypass over EBT as the preferred method of revascularization. And again, I've just highlighted the Planet criteria for average surgical risk. So these are 54.4% of their patients could have possibly been changed into the average surgical risk with a better outcome. Like any study, this study has limitations. I just want to mention before I conclude, this was non-randomized, retrospective. Therefore, surgeons made decisions that could have introduced selection bias. EBT, as I mentioned, the demographics portion of my talk, was a treatment of choice in older patients with shorter lesions, a lot of comorbidities, or they were non-ambulatory. Bypass was the treatment of choice with extensive lesions, major tissue loss, if they had single segment and an acceptable operative risk. The severity of chronic renal insufficiency was not stratified according to renal function. And the last thing, that I noted on this paper was the global anatomic staging system, ideally in the guidelines, is supposed to be performed based on angiography alone. That is how you determine the stratification within glass. However, this study did use glass using cross-sectional imaging and or angiography. I just want to take a brief moment, first of all, to thank Dr. DeMuzio and Dr. Humphreys for inviting me again this year. I've both met you both at conferences, and it's just really great to see you again. I do want to thank my faculty as well for having me do this and giving me the opportunity, and I will leave it to the group and stop sharing.
Well, thank you very much. As we mentioned, the authors are not going to be here for this discussion. And so we're going to rely on everyone and a few people to help us a little bit with this. So I'll start with one thing that I noticed in here, which for those of you that are not super familiar with PLAN, which come from the global guidelines, one of the things is we're actually having a webinar on PLAN in a couple of weeks or months so that we can sorry, Paul, could you help us? Paul, could you help with that real quick? I feel like there's somebody that's potentially not muted. So maybe you could help with us to get everybody muted. So that would, thank you. Yeah. So we're actually, as I was mentioning, there's a plan for webinar, or a webinar for PLAN. Sorry, confused myself there, but one of the things that we have talked about in using and coming up with PLAN is the concept of the calculator. Yeah. So I found it very interesting in here that they used kind of the risk factors that they chose. For most of the time when we're talking about PLAN, the SVS has a web-based platform in the app that can allow you to calculate the mortality for patients with CLTI at 30 days and at 2 years. And it's one of the things whenever we're seeing patients in clinic, it's a BQI CLTI mortality predicting model that was developed by Jess Simons several years ago. I want to say it was published in 2019. But it has a number of different factors that it looks at: mobility, beta blockers, it looks at various different things. And the outcomes for that are a little bit similar to this, except that they included albumin, which is not included in the calculator. Yeah. And so I found that a little interesting.
Yeah. I'll comment on that. Is I wish the authors could have joined us. Obviously, it's a little difficult because A, they're in Japan, and B, there may have been a language barrier. But it would be interesting to know, what kind of frailty scores they use and scoring systems in the CLTI guidelines in reference to comorbidities and frailty. They list about 18 different scoring systems. So I think studies like these are really important, but it would be nice to have I think we have more of a national, standard that we all try to align to. It would just be interesting to see what they use on a daily basis as their kind of gauge of, where they place their patients within the Planet algorithm.
And Dr. Hingorani brought up a great question and point too. I think it would be good to see that cost benefit analysis. In providing advanced endotherapy with drug-eluting systems versus a bypass, I mean, is this, bringing these patients back, dealing with restenosis, dealing with reintervention, is this economical, or is a bypass not economical either? If they're going to lose a limb within, a year or two, are you providing really good economic savings? And I think that's a big unknown. And as healthcare is starting to shift, I think this is going to be a big area to really look at in the next research projects.
I'd like to make a few comments about the paper. Can I?
Yes.
Oh, so Joe, I just like to point out to the listeners that maybe you may not have noticed this, but Japanese CLI papers typically have between 50 to 60% dialysis patients, whereas a lot of the Western papers will have 10 to 15% in general. So this is something that is very noticeable. A lot of the so they have a very unique situation, and this is a very, very well conducted study, very well studied. It's a nice study, but and there's a lot of good messages. One of the most important one, obviously, is that actually about 55% of the patients overall were actually had only one 0 to 1 risk factor that would make more than half the dialysis patients, at least in Japan, be eligible for considering bypass. And these patients who do better with the wound healing and all that. But I'd like to point out one thing, though, that my criticism is like, whatever the statistical thing they came up with, when you put the non-ambulatory there, so when you just think this through, so when you have a non-ambulatory patient, although they are less than 75 and the albumin is 3.6, I mean, forcing, that is not a patient that a lot of people would necessarily, especially if they have, say, a heel gangrene or this and that. So the non-ambulatory part, I'm finding a little bit of a statistical thing, and it may not be clinically as much applicable. But the other ones, obviously, nutritional status and the age, obviously, do have much more weight than that one. And it's not clear how many patients actually were in the one category, just non-ambulatory, and everything else, like those patients. So it may be based on a very small number of patients in reality. I just wanted to point that out to people. Thank you.
Paul, you asked a little bit about the SFA, and if you could tell necessarily about the how many of these patients had SFA versus infrapopliteal disease. And they use the GLASS classification, which when you put it all together, it's this 3D matrix, and then you get into a stage of 1, 2, and 3, and it can be can be all of these different combinations. And sometimes that's really challenging. I think because we aren't using GLASS, say, in VQI right now, or not everyone has converted to GLASS, I'm not really sure how to sort of put some of this together yet. And I have to admit, I didn't go back and look at, the various GLASS classifications and this to even kind of determine that. But I don't think I saw that specifically. Dina, did you see that?
So you're talking about, they have some supplementary tables that do talk about basically the extent of the lesions, et cetera, and then what kind of bypass, but they didn't really get into the GLASS and that whole matrix thing. Additionally, I do want to point out that in the US and according to CLTI guidelines, the way you get glass is you actually do a diagnostic angio on these people. So, you know, a lot of patients, they want their angio and they want an intervention, but this study, it doesn't say exactly who got what, because you know, that's just the nature of this study, but they did cross-sectional imaging and or angio determine their glass. So there may be kind of a layer there where the glass that they used for this paper is not as accurate as their angio, you know, which is a high quality image, et cetera.
Dr.
Yeah, I think
Humphreys.
that, yeah. Hey, Dr.
Yeah, you had
Gonzalez,
mentioned
how you
that we
doing?
don't. Pretty good. How are you? You had mentioned that we don't often use glass in the American literature. I was wondering, like, if you guys had some thoughts on what are the barriers to using glass for like standard reporting.
Well, I mean, I do think one of the things is that we haven't transitioned in terms of VQI. VQI is still using task, and you're still asking people to fill it out based on that. And that's most of these classifications are used in these databases, but they're not used on a regular basis. So when I'm talking to a patient, I don't walk up to the patient and say, oh, you know, you have this TASC lesion. You know, it's not something that we typically put in our notes. My patients would know what it is. None of the consultants would know what it is either. So it's not something that we've used. We use it for research basis. We use it for quality kind of things. We use it in that regard. So that's also part of it, is because you have community practitioners, a lot of who are not in VQI for the lower extremity. They used to be in VQI maybe for the carotids. It's not something that we typically need to kind of go through. And I think that's one of the bigger barriers. I don't know if anybody else has some other thoughts on that.
Well, I'd like to point out one thing, that the glass classification was really specifically for the CLTI patients, right? So it doesn't really, when you're, a lot of the papers are classifying the lesions and everything still on the task, and the glass and all that inline flow, everything doesn't really apply to claudicants either. So then when you're going for lesion descriptions, and then the glass is limited to CLTI patients. And that's kind of makes it very hard to adapt to a lot of other ways, where the lesions descriptions are you going to go to task for claudicants and glass for the other one? So I find that to be a little hard to navigate, and people are used to the task a lot.
Well, I do want us to have plenty of time, since the authors for the next paper are here. So I'd really like to give them an opportunity. So thank you both, Dr. Fagali and Dr. Chihara. I think this was a great discussion, even though the authors couldn't be here. And now we'll move into our second paper.
Thank you very much.
Okay, so let me get started over here real quick. Let me share my screen. Okay, so good evening. I'm John Maib. I'm with Indiana University. And our paper, I actually found quite interesting, because I think this is something I use a lot, definitely in my practice. I know my partners do as well. So we're discussing the paper out of Duke University, Risk Factors and Consequences of Wound Complications Following Sartorius Flap Reconstruction. Now, I mean, I think we all agree that a femoral vessel exposure is something that we all do quite frequently, right? Lower extremity bypass, femoral endarterectomy, access for endografts. And even despite our best efforts, even with careful technique, wound infections and complications still develop. And I think we all know that whenever you have a groin wound breakdown, it can be a little bit unsettling, especially if you know you have a bypass under there and you start to get a little anxious about that. So in that setting, you know, we have options for soft tissue coverage and salvage. You know, there's the gracilis flap, the rectus femoris, the rectus abdominis, or VRAM. But by far and away, I think, you know, in our practice, and I think in a lot of places, sartorius is very common. And I think the sartorius flap is something I think most vascular surgeons use in their practice, in addition to plastic surgeons. It was first described in 1948, really as a way to provide coverage of the femoral vessels after inguinal lymphadenectomy. It can be easily accessed within the same incision, and it allows for excellent coverage of the femoral vessels and promotes an environment essentially for healthy wound healing. So for our trainees on the call, The blood supply of the sartorius flap is on the medial aspect. We do our dissection on the lateral border. And essentially what you do is you take down the insertion on the anterior superior iliac spine, and you're basically going to take the that muscle and you're basically going to rotate it over so such that the normally anatomic anterior portion of that muscle is now abutting the femoral vessels and can be secured to the inguinal ligament. This is some pictures from our institution performing a sartorius flap. Over on the left-hand side, you can see the sartorius flap is starting to be raised. And then here we you can see the pickups trying to point out basically the vascularized pedicle for the sartorius flap itself. And it is important to always remember that and try to preserve it, because otherwise your flap itself can necrose, and then you really haven't helped the patient at all. Despite, the fact that we have this, and the idea being it's going to promote healthy wound coverage, there's still plenty of complication rates after these. And I know I've seen it after I've had some of these sartorius flaps. Depending on which studies you look, it ranges from 20 to 40% wound complications after sartorius flaps. So I don't think it's realistic to say that we can eliminate all wound complications, but I do think in what the authors were doing is it's important to identify what these wound complication risk factors are after sartorius flap creation. So in their particular paper, it was a single center retrospective review looking at the demographics, the indication for the flap, comorbidities, obviously the index vascular procedure and what the outcomes were. The primary outcome being wound complications following sartorius flap, and that complication is basically defined as infection, dehiscence, or lymphocutaneous fistula. And so with that, I'm going to turn this over to Rohan. Stop sharing.
Okay. Thank you, Dr. Mahoub. So as he gave us a great introduction here, we'll be discussing the sartorius flap paper from Duke University from this month's issue of JVS. Thank you, Dr. Humphreys, Dr. DiMuzio, for having us host. So just briefly about it, as Dr. Mahoub said, it is a single center retrospective review. They identified 113 patients over the course of an 11-year period between 2012 and 2022. A little bit more background, on literature review, the incidence of groin wound complications is wide ranging from 11 to 44%. As we alluded to, there's particular concern with vascular reconstructions underlying these groin wounds, especially in the setting of graft infection or loss of integrity of your anastomoses. Sartorius flap is a very commonly used muscle flap to, number one, reduce some of this potential space, but it also provides a well-vascularized tissue coverage of these repairs or the underlying tissues there for the delivery of oxygen, nutrients, in cases of infection, antibiotics, and leukocytes. So the way this group identified these patients were based on CPT codes, but they did do an additional review to ensure that sartorius flap was indeed the muscle flap procedure that was performed. It was done by sometimes vascular, sometimes plastic surgeons in this series. They did collect information on the nature of the index procedure, as well as any kind of culture data that was available, and the indications for the procedure. The primary outcome was any wound complication after the flap, defined as a dehiscence, surgical site infection, or lymphocutaneous fistula. Secondary outcomes included unplanned 30-day readmission, unplanned return to the operating room, as well as mortality within 30 days. The statistical analysis was done with a logistic regression. They did a multivariate analysis, included any variables that had a p-value threshold less than 0.1 on univariate testing, with a significance for the multivariate testing of p of less than 0.05. So brief overview of the demographics. The groups were the same in most aspects. However, the group with the wound complications had a higher average BMI, as you can see here, with a p-value of 0.03, as well as a higher rate of active smoking in the wound complication group. Notably, with respect to a lot of these comorbidities, they were the same, as well as age, sex, race, and the indication, whether it be therapeutic or prophylactic. So the outcomes from the paper note that there's a higher percentage of wound complications in the prophylactic indication group. We'll talk a little bit more about this in the discussion section. And then the wound complication group was also associated with a higher rate of 30-day readmission, reintervention, whether that be on the vascular repair itself or redo flap independently. The other complications were associated with higher BMI in the multivariate analysis. There was a trend to significance with active smoking, which was included in the analysis as it reached the threshold in the univariate analysis for inclusion. Reintervention was also associated with wound complications, with the flaps with a prophylactic indication trending towards significance. And then 30-day readmission, of course, was associated with wound complications as well. Diabetes and coronary artery disease were also included in this portion of the analysis and appeared to also trend towards significance here. I just included briefly some of the supplemental data. There were no statistically significant differences between the groups here with the wound complication versus complete wound healing groups. But on the basis of wound culture data, skin closure type, meaning suture material used or staples, as well as the use of drains or incisional vacs, there was no difference in terms of the outcomes. And the graft salvage rates were similar between groups as well. The ultimate discharge disposition was also similar between groups. So overall, the rate of complication was around 25%, similar to that to published data from other institutions. I think it probably suggests that sartorius flap aids high-risk wounds such that the rate of complication is similar to literature that you see for both sartorius flap reconstruction as well as just groin complications in general. The higher BMI was associated with groin complications as well as active smoking, seeming to trend towards a significance. The higher rate of complication in the prophylactic flap group, it may suggest that the decision intraoperatively to do a flap prophylactically may be selecting for a group that is higher risk for these groin complications to begin with. And then these wound complications, I think, unsurprisingly, were associated with readmission as well as higher rates of reintervention. So overall, I think this is a useful technique in managing groin complications or perhaps preventing them. The optimization of patient factors and comorbidities likely plays a large role in the management of groin complications. And it's important to follow these patients up, especially patients undergoing sartorius flap for high-risk wounds or for salvage, to identify these complications, which are relatively frequent associated with this type of repair. Again, thank you for the JVS Journal Club for inviting us to host here, and thank you for the authors for being on as well. I'll stop sharing my screen so we can discuss.
So I guess maybe I can open the discussion and ask my questions to the authors. So I think this is a very interesting paper, and it's a single center larger series. And the most important message that I got from this is the pointing out to the high complication rates, not only from just actually the sartorius flap when it's done for treatment of the groin complications, but also when it's done for high risk groins. That is like up to 30+%, and that's a lot of complications. The main I could not really understand the exact methodology and why the authors chose to bundle these two very separate groups together. And then, it is making it very hard to understand exactly what's going on, to really learn from this very interesting and large experience, in the sense that, for example, there is no real deciphering of the actually graft preservation in the different groups, like what percentage of patients. So the wound complication doesn't even list that, because not everybody had like grafts under their wound. But it's very hard to actually understand. For example, I still don't know, after reading it multiple times, when you do a prophylactic flap in a patient with a synthetic graft under there, what percentage of them were actually salvaged. So, but when you have a wound dehiscence in a prophylactically, managed groin, if the wound dehiscence happens, but the graft is not to prevent wound dehiscence, as they kind of mentioned in their, discussion too, it's to prevent graft exposure that's way below, under the muscle. So that's one of the major problems I have with that, is like I can't decipher, when you bundle these together, how to decipher this whole experience, because they're very different in which patients. So lastly, because of these very high complication rates, I have been having problems. I had problems with the sartorius flap myself, because when it fails, you have now a bigger gap. And also the fact that sometimes your graft is crossing over, it's not easy to flap. So I have turned more to the gracilis flap. So I would like to hear from the authors. I mean, this is an option. It's been widely used, but since you're duplicating the literature on relatively not so great outcomes after, even in a prophylactic setting, wouldn't you actually at least discuss to consider using some other flap? Like I've changed to gracilis flap more for groins. Thank you. It was a great paper, though.
Yeah, I would say probably our go-to flap for sure is still sartorius, and then if the sartorius flap fails, then we tend to would involve plastic surgery at that point for sure, for either a rectus femoris or a gracilis flap. Yeah, I do think bundling prophylactic and therapeutic into one paper instead of splitting it in two does sort of muddle the message. Because like you said, graft salvage is sort of the name of the game. Although obviously not everyone here had a graft, that was being salvaged in this paper. Yeah.
I was going to say, I think that, for these patients, especially with the larger BMIs, I think we all expect that if there's any patient that's going to have a groin complication, it's going to be in those with obviously elevated BMIs, right? What this does tell me, I think, is that doing a prophylactic flap on those patients where you might consider it or whatever, that may not change your actual, outcome. So I do find that useful part of this paper. My other question is I know, most of the vascular surgeons, especially when I went through training, we didn't place drains on these sartorius flaps. But our plastic surgery colleagues that we have at IU, routinely, every single flap gets a drain. Is that pretty commonplace for you all too? And I know looking at your data, you did account for that. It sounds like you didn't see much of a difference there either.
Yeah, my personal practice is I either leave a drain and close skin with staples, or don't leave a drain, don't close skin, and vac it and let it close by secondary intention. And the more worried I am about it, the more likely I am to vac and not do the drain. But in our series we didn't have a huge lymph leak, but and that may be because drains or vacs were, they weren't being diagnosed, but they were there, had you just closed it with no drain or no vac. But yeah, I find the lymph leak quite high after a flap, which is why I either leave a drain or vac it.
A specific question now. So now you're saying that so when the real control of the prophylactic group could have been the high risk groins that did not have the prophylactic, which you don't have in this paper, obviously. So now seeing this experience, so who do you actually put prophylactic sartorius flap in which patient? I mean, you're going to have about 35% womb complication rate with that. So you think you're decreasing from a 70% to 35%? Or what is how did this paper or work affect your approach?
Yeah, I do think, given that with the high complication rate of the prophylactic folks, to me, the only reason to do a prophylactic sartorius flap is if you have prosthetic in the groin, because otherwise, because that's obviously a disaster. So, high risk, obese, smoking, comorbid patient with prosthetic in the groin, that's a reasonable and redo groin would be a reasonable person to flap. But obviously, if it's a vein bypass or just in a high risk patient, I would not do a flap and just let them get a wound infection if they're going to get it.
Are you guys using Provinas routinely in grafts or obese or higher risk patients de novo? Or are you just putting a standard dressing? And what is kind of your approach?
Provena, that was a really big fad at our institution, and it's captured somewhat in this data set undoubtedly. But I would say currently most of us are not using Provenas, but that was something that kind of entered our division pretty heavily for a while there. But I think folks just didn't see a huge, and this is my read of our current situation is they're not being used that heavily for groins.
Yeah, we're very heavy Provena users. We've looked at the data, and we've actually, back in Philly too, had done some studies looking at the outcomes that did significantly decrease wound infection, obese patients, redo femorals with a prosthetic graft. Obviously, in a healthier saphenous or any kind of vein conduit, that risk is lower, so the cost saving is not necessarily needed. But I think, as Missy said, there's also data now that staples, particularly in AMP sites, BKs, AKs, or in femoral, the risk of infection has come up too. So I think that's something also to consider.
Yeah, I mean, I just put in there out of curiosity, you mentioned the staples, and I just kind of heard that. Do all of your patients get a stapled closure in the inguinal area, except the ones that get a vac? Because I do always kind of think about that in my head about the higher rate of infection there.
Not all of them. Yeah, I mean, within the group, I know some people are like always monocryls, and some people are always staples. I tend to, I am aware that, yeah, there is data even from our institution that says there's a higher rate of infection with staples. I don't know. Yeah, but I do staple, I don't know, a decent chunk of my inguinal incisions. I would say anybody who's getting a bypass, a vein bypass, gets staples down their entire leg. Um, the like a PTFE FemPop is probably getting a monocle closure with glue is probably that's probably my algorithm there.
Yeah, there's a question about the blood supply when you're using sartorius flaps. Do you consider the quality of the lateral circumflex or other branches when you're choosing that graft versus some other graft? Or
I've heard, if you have a diminutive profunda or circumflex, that you're more likely to have a SART die on you. I can't say that I've had like a no profunda situation where I chose a different, like a non-sartorius flap. But yeah, if I had a ligated profunda, then I would want a different flap than sartorius.
mm-hmm. So were there any patients who had also antibiotic beads placed with the muscle flap? Did you ever use that, antibiotic beads?
I don't believe there were any antibiotic beads used in this. I tend to aggressively use rifampin on my groins. It's just my personal little voodoo. But obviously there's good data for Dacron soaked rifampin in infected fields. And I just, it's cheap medicine, so I soak my bovine patches in it and pour it on my PTFE bypasses. But no one should like take that, and I'm not trying to spread that. It's just what I do.
So I'm going to ask you. When the groin problems after surgery is like the graft being there is not a graft infection. So it's like graft present in an open wound or something. Most of the early groin problems So do you ever consider even just vac and not? I mean, I wrote a paper on that one, just vac on just exposed grafts, and although I do use more gracilis muscle these days, but so do you ever use like a local wound care like with the vac on graft or something like that?
Yeah, if it's an extremely superficial dehiscence, and especially if you have like a CTA that shows that it's superficial and it's not deep, then I think just vac, no flap is fine. Again, if it's an aorta bifem, I would worry more about it, than like a FemPop bypass. So that might lower my threshold to just go ahead and do the SART flap, just because the consequence of that is so dire. But yeah, no, for sure, like a superficial dehiscence that doesn't appear very infected, we'll vac that and not flap it.
Okay. So did you look at longitudinal versus transverse femoral incisions? I believe that was no difference in there, correct? In the incisions being longitudinal versus transverse?
Yeah, I don't believe there was a difference in our series, although obviously other series have shown transverse has a lower rate.
So there was a very old paper from Albany Group. I just remember now that they did something like approaching the femoral vessels from a lateral, moving the lymphatic tissue more from the lateral down to medial versus the medial. There was a much less lymphatic or wound complications that way. So it's something that I kind of made a mental note about that for many years ago. So I don't know if anybody's aware of this old paper. That was an interesting one. So slightly more lateral and medial like approach to the femoral axis in the groin.
looks like a couple of people in the chat had mentioned that they do that. So
Oh, they do that. Yeah. Okay.
perfect. Well, thank you, Dr.
Those
Salasu.
tools, yeah, that's right. Don't worry.
Perfect. All the S's and all the letters,
Yeah.
the L's got me confused there for a minute, but for being our moderator. And thank you, Dr. Williams, for answering so many of the questions, as well as Dr. Longano. This kind of ends the end of the hour. I think we've had a good discussion about sartorius, great discussion always about end-stage renal disease patients with chronic limb-threatening ischemia and where to go in that regard. Our next JVS Journal Club will be March 13th. We will be posting that on SVS Connect, both in the general discussion as well as in the program directors. And then it's also on social media, and you can also find us again on vascular.org. So have a great Valentine's Day tomorrow, and we'll see you in March.
Thank you for inviting me. Have a good night.
Thank you.
Thank you. Night.
Have a great night, everybody.